For sharing your insight and expertise. Obviously, a lot of taxpayer dollars are involved in the subject matter here today, and I certainly want to do my part in making sure that it is spent wisely. Common refrain that I hear when I visit hospitals across rural Nebraska is that the providers and administrators are certainly proud of the equipment that they have, but they're also concerned about their inability to meet the meaningful use requirements, and that they can't even communicate effectively with other providers or hospitals. And small hospitals have expressed concern that after their upfront investment, they have to continue paying licensing and maintenance fees on their systems, which certainly can challenge each and every one of their budgets. Now, based on these concerns, I do have a couple questions, so if you'll help me out here. I hesitate to suggest a one-size-fits-all system because I doubt that would work, and I don't know of anyone up here who would support that. But how can we ensure that this technology, which has been purchased perhaps, can actually communicate one with another or even universally?
That's fundamentally what we do when I talked about our interoperability platform. I agree that the dollars have been spent, and that's one of the other the distinctions that we have as a company is that we don't advocate ripping and replacing electronic medical records. We say the investments have been made. If the record doesn't work, or if you have problems with your current supplier, or they've decided not to go for MU3 compliance, then you have a problem, go do that. But if you have one, make what you have work and have it be interoperable. And if your supplier does not have an open approach, then we will help you as a client get that data out. Everybody adheres to some level, to some form of standards. MU1 and MU2 guarantees that, so we can get the data, and I can emancipate that data, if you will, from the EMR if that needs to be done, and there's some sort of effort on the other side from people not wanting to make that available.
So are you suggesting that with relative ease it can already be done, ease and or low cost?
It is not necessarily easy, but it has been done at scale with a lot of very large organizations and some very small organizations. I've got people as large as HCA that uses our solution, and we have a client up in Vermont, a small 50-bed hospital that's trying to connect to 45 different physician practices to make all the information in that community available to one another on 5 different electronic medical record platforms.
And I might suggest that facilities do actually get quite smaller than that.
Yes, sir.
And yet I sense they are burdened even more so with the requirements and the mandates and the costs and the hoops, in very remote parts of our country. Now, on the topic of cost and so forth, can you demonstrate that there's enough competition in place right now, that there's actually downward pressure on these costs? Because, talking to providers, I take away from them that they are concerned that their costs are just spiraling out of control in an upward fashion rather than more competition driving down the cost.
Yeah, there's a lot of competition in this marketplace. There's over 450 different electronic medical record suppliers that have been certified by the ONC, and there's various different models for pricing in that regard. There's license models, there's SaaS models, which is a software as a service, and there's actually one of the companies actually offers a software for free. They make you look at advertising from pharma, but it is a free electronic medical record. So there's lots of different models that have been put out there. Over time, value gets displayed by what outcomes you're able to deliver with your client, and that's something we focus on very vehemently, which is we want to make sure our clients are successful in using these systems to connect, to transfer data, to look at it from a community standpoint, and then move that information once it's been analyzed back down to that caregiver so they can actually take action at the bedside, at the home, or wherever that might be.
Okay, thank you.
Thank you.
Thank you to our witnesses. Thank you, Mr. Chairman. I yield back.
Thank you.